Dr. Choi, I think maybe it's just me, but I can't hear any of the audio.
This is why not, this is why none of the recordings worked. This is I don't know how many times I've done this. Oh, and I've had I'm gonna take off. Do you still hear me? Because I had my AirPod and I was so excited to use it. But I guess I didn't realize.
No, I still hear you now, but we just
I feel
been.
like the fool. All right, I'm gonna go back. Holy,
Okay, thank
I almost swore in my
you.
head. I can't believe I was such a fool. I was like, WebEx sucks. Like IT sucks. Oh no, I shouldn't say that. WebEx sucks at school. Like I can't hear myself. And I thought I tried everything. Of course, I had the AirPod on the whole time and it was muted. Oh my God. All right, this is gonna be cut off. All right, I hope you don't mind that I'm gonna start over. That was only 13 minutes of your wasted time. I'm sorry. All right, so here's the final exam review breakdown of the questions. I didn't include the RPD, the conventional RPD topic. That's going to be in the spring. I'll explain to you why. Everyone did well on these scenario-based exercises. I would say, and I don't know why it's advancing by itself. But the RPD one, almost every year we don't do it as well. But anyway, so after the midterm, this was the first scenario-based exercise, which was on record making and teeth arrangement or teeth selection. Everyone, did well here. Pretty much, I included all the questions with the right answer here that's highlighted in green and how much of the class answered it correctly. So again, these numbers are very high. Same thing here. So I would just ask you to review it on your own. If you have any questions, you can ask me. But, I try to ask questions still based on these questions. So I don't think it's going to be that difficult. But as long as I found these concepts are important, I mentioned them. I used them in the exam. 100%, obviously everyone read the tooth mold guide correctly. That doesn't always happen in the clinic. So I mentioned that the scenario-based exercise on RPD isn't included. And that's because for some reason in the past, this course had another exam, but in the spring. And that exam in the spring was just on RPD, design principles and concepts. And the only thing I can suspect why that is I think this course used to have a clinical component. Now you have the assisting as a component to add on to your grading. But back in the day when we had more, can I say, pros chairs and pros instructors, they used to have a removable clinic and they could afford to offer a lot more removable experience for the students. And so whatever they did in clinic, the grades they got in the clinic got incorporated into this course. Now that's not the case. I think the academic affairs and the course director in the past discussed how we can add a component to the course that kind of reflects clinical experience, which in my opinion is not really feasible. But anyways, we added another exam in the spring, and that's on strictly RPD design and principle. So I don't have much say in that scheduling, as well as the fact that we're continuing with this exam. And it's actually considered a competency exam, again, because it used to have a clinical aspect to it. when that time's near, you'll get a reminder from me, as well as a kind of a refresher on RPD design. So like I said, we don't tend to do as well on this topic as others. I'm glad to see everyone would articulate CAS before jumping into surveying and designing the RPD. And I showed you a picture of this. This was an actual picture from one of the social media sites. And oftentimes when you read the comments, they say nothing but good things. And a lot of things stand out to me here as something off. So I was glad to see that most of you wanted to change the inferior part of that external finish line to be a little bit more acute, so that we have a little bit more bulk in obtuse angle in the acrylic. And then I asked you about what you would do, if anything, to this area 28. I'm sorry, if anything in this major connector area, or the whole thing. And a lot of answers simply indicated we would change this bar-like design to lingual plate. And I didn't ask you for reasoning or explanations, but I was hoping you would include that. Well, I didn't mark any answers off, even if you didn't have explanation or reasoning. But I do hope that, especially when you're in clinic, if someone gives you an answer, someone tells you, do it this way, I hope you ask a follow-up question, simply asking why. Why do you want me to design a partial this way? Why do you want to prep the tooth this way? There should always be understanding of why rather than how and what. So what I was hoping to see, well, if you said you wanted to change the bar to plate, you should have some reasons, and we talked about that. And I think most of people who actually stated why they would do it, why they would switch to the plate, they actually included some of these reasons. So that was good. I was hoping someone would mention this area, because this was just glaring at me as soon as I saw this on this social media page. And the best answer I saw was, well, first we start with the dimension of the bar. We usually want 8 millimeters of space from the gingival margin to the depth of the vestibule here in the sublingual area, because we need about 4 millimeters of space between the superior aspect of the bar to the gingival margin if we're doing a lingual bar. And the lingual bar usually tends to be 3 to 5 millimeters. So if you add it up, it's about 8 millimeters of space, right? So this answer did basically mention that dimension aspect of the bar. And on top of that, it said, well, it shouldn't have this sharp turning point. And if you went further, anything sharp like this on a major connector, it's basically a potential site for flexure or even fracture. So over time, anything kind of folded or sharp like that, it can flex, and as a result, eventually it can break. So I was hoping a lot of answers would say that, but I only saw a few, but that's okay. This one I was a little bit more glad to see more students mentioned they would change it. Now, again, simply just saying I-bar, potentially we're forgetting why we would do I-bar, why we wouldn't do I-bar. There are many reasons, and a lot of it has to do with some anatomical obstacle, right? So we have severe undercut from both soft tissue and tooth, or either. Frenum is attached too close to the tooth in the way of the I-bar, or the vestibule is just too shallow. The I-bar, as you know, is in for a bulge clasp that needs to come down from apical portion of the tooth, and if there's not enough space in the vestibule, we just can't place it. But like I said, I was glad to see that everyone almost wanted to move the distal occlusal rest to the mesial side to avoid the class 1 lever. So I was glad to see that. And the last question entailed this picture, and this was kind of a combination fixed and removable situation. And I first asked, what is the sequence of this whole treatment process? And there are a lot of steps because it's involving both fixed and removable. And I was hoping, again, people would remember to do the diagnostics. It starts with the preliminary impressions, mounting casts or articulating casts. I'm sorry, it keeps advancing by itself. I'm not even doing anything. Maybe my computer's starting to act up after 8 years. And then we, after having the diagnostics, we have surveyed the casts, we have designed RPD, because you should have that before starting anything, either fixed or removable. That design gives you a roadmap. So with that, you go forward with preparing the teeth, make an impression, get the crowns back, deliver the crowns. Now you do the impression process for the removable aspect of this treatment. So you might do border molding. You might then do impression for the framework. Framework comes back from the lab, try the framework in, fits well, do the jaw relationship, arrange teeth, send it back to the lab, it gets processed, now you deliver, now if everything goes well, kind of done with the treatment. So I find this, even as I explain it, it's very elaborate, it involves a lot. For that reason, I see this taking a lot of time in the clinic, especially because it entails a lot of lab work back and forth. But I also find this very rewarding, and I see it both in your eyes as well as the patients. So I hope you get all you need is maybe just one patient that goes through both fixed and removable treatment at the same time. I was glad to see, again, a lot of people answer this correctly. So you can review this again if you like. Again, RPD questions are not really on this exam other than the rotational RPD, which I'll review. Same thing with this last question, diagnostic wax up. That should be a blueprint for everything, not just for removable or fixed. That's what that question was about. So speaking of rotational RPD, that is actually going to be on the exam, I try to just pick the ones that are really relevant. Unfortunately, we just don't see a lot of rotational RPD being done in the clinic anymore. And that's not just on the instructor or the student. It's also the lab. We got to make sure the lab understands the principle behind rotational path RPD. Sometimes we don't even get a good lab support on conventional ones. So if that's the case, how can we get it on more advanced type of design, which is rotational? Conventionally, there's basically just one path of draw for insertion and withdrawal. Whereas rotational path, that path of draw or insertion is different because we have now a rotational or what's the other one? There's another one coming up. Basically a rotational center that allows the RPD framework to pivot or rotate into a full seating position. If you review this presentation from Dr. Frone, it's got, sometimes you can have a single rotational center. You can have make two, so you have more options in that sense in terms of rotating in the framework. But the basic premise is to be able to have that rotational center have a very rigid portion that once you seat that portion and rotate the framework all the way down, because that portion around the rotational center is rigid, it's going to be almost like kind of locked in, especially without clasps. I think that's the important point, that we're not getting rid of clasps for because we just feel like it, but because we actually have something that replaces the function of clasps, which is retention. So having this rigid portion of RPD on this picture will be here on the left side where it's labeled as A. This portion is very rigid. You also notice that it actually engages the undercut of the mesial of this molar. We don't usually do that with a conventional RPD because we actually block out some of the undercuts in the guide plate area or guide plane area. But that's the difference. But if you simply break it down to simple terms, this works probably the best when it's tooth-borne rather than tooth and tissue-borne RPD. If we want to get rid of clasps in the anterior region because it's very visible, this is again another indication. We want to, the last point here, it's a benefit rather than an indication of rotational RPD, that by having a rigid portion around the rotational center and being able to get rid of the clasps, that reduces how much the metal framework is actually contacting the tooth, and as a result, we don't get as much food trap. So that's good for the patient. And Dr. Fern showed this is exactly what rotational RPD is. If you understand how a ski boot inserts into a ski, I think you get the concept. You have to insert that toe portion of the boot. There's a little groove there you slide in, and it may move a little bit, but when you step down on the heel portion, obviously it locks into the posterior portion, and you're really locked in until you push on the release lever. So that's very much rotational RPD, which conventional RPD like this one doesn't have. There's nothing kind of locking in, which is shown here as a rigid portion in the anterior. As I said, it's almost engaging going into the undercut on the mesial portion of 7 and 11 here before it's rotated posteriorly to full seating. So you can have either one of these. By the way, I'm going to go forward because you can read these on your own. Let me see here. Sorry, I'm sure you're seeing my mouse go all over the place. I think there's a reason why I put a little red asterisk here. You may be able to guess why. If not, at least by the end of the review, you'll understand why I put that there. Advantages, we mentioned some of them. Disadvantages, I didn't mention, but you should know as well. These disadvantages, not a lot, but one thing I didn't include here is, it's very technique sensitive. So if the lab blocks out the undercut in those proximal areas that I mentioned that really incorporates the rigid portion of the framework, if they block it out too much, it's not going to engage. If it doesn't engage, then there's no retention. And there's no point of doing rotational RPD. More information. Okay, here's a very good example of when we would have rotational RPD at least considered in order to get rid of clasp or clasping in the anterior or very visible area. So you can see that this proximal plate on the distal of the canine, it almost is going into the undercut. Whereas you see this proximal plate on the mesial of molar, you see a little triangle, black triangle there. So that's not really engaging per se. But this gets inserted first, and then this slides down with a rotational center at the canine. There's again that red asterisk on this picture slide for some reason. This one obviously shows you, well, you want to start with this cast as flat as possible as you're surveying, because we want to make sure that we do indeed have an undercut on this proximal surface, let's say of this anterior teeth that we're going to try to engage with a rigid portion. After that, I'm going to tilt it to a point where that undercut is not very obvious. Basically, there's no undercut. If you put it up like this, it's almost perpendicular to the horizontal floor. And we want to now tripod it this way because the lab has to imagine that there's no undercut. If you tripod it this way, it will see the undercut right away. And again, that's when maybe the lab tech ends up thinking, I got to block out these undercuts. But in reality, we don't want to do that for rotational RPD. More surveying, dual path. I mentioned to you that you could have more than one rotational center. Some problems, well, what happens if we have to consider issues not anterior posteriorly, but laterally? So teeth are lingually tipped in this example. What do we do? There's a solution for that too. Obviously, we can't clasp. If we look at undercuts, it's really the lingual of these molars, but we can't clasp them because how they're tilted. So lingually, you don't have path of insertion or draw. So you have to not include clasp, but we also at the same time still want retention in these areas. Well, as I said, you can't see it here, but the guide plate is going into somewhat of an undercut on the mesial surface of these two molars. The rest seats are also prepared almost in parallel walls and long enough mesiodistally that also creates nice retention. So you'll find that preparing rest for rotational RPD can be, let me see if I had that slide before, can be pretty technique sensitive, I guess. You have to be very accurate with your rest seats. Otherwise, if when you're trying the framework and it just doesn't seem to seat all the way, it's not because the framework was made poorly, but perhaps the rest seats just weren't done properly. And there's just very little room for error with rotational path RPD frameworks. And I would say if we go ahead and adjust these rest areas or this area as in general, because this is actually part of the retention, if we adjust it so much, we lose that retention altogether. So the only thing that's going to provide retention for this class 3 RPD design is the anterior class, which is not very much. We really want some retention from the posterior to posterior areas as well. I think I, by accident, gotten rid of the slide that talks about that. So I'll include it, but if you heard me once here, you'll be fine on the exam. So the other scenario-based learning exercise was the post-delivery complications. And we're back to doing pretty well on this one. Correct answers, most people picked. And I was, again, glad to see every question we did pretty well. And I really didn't veer away too much from these questions on the real final exam. Speech, again, I try to pick what was probably the most relevant to your clinical experience. There's nothing we can do about respiration. It's not something that we can change with a removable prosthesis. Phonation, is another thing that we can't really change because it starts at vocal folds. Resonation, however, especially someone with extensive treatment surgically, let's say maxillectomy, or whether it's partial or complete, if there's a lot of the palate missing congenitally, that could affect resonation. So here's that slide: congenital findings like cleft palate, or surgically something was removed, that can lead to basically lack of resonation, and we need to have prostheses that help improve that. Articulation is obviously when our prosthesis gets involved, whether in a good or bad way. Our prosthesis has to respect all these structures in the mouth. When patient is edentulous, obviously we need to position teeth properly to be in harmony with all these structures. So I'll just keep going here. Some sounds that she mentioned. Neural integration, again, our prosthesis doesn't affect it. Same thing with audition. More sounds, and here are some sounds you definitely should know. The fricative sounds, when you say 55, that word has both the F and the V sound. When we say it properly, the incisal edge of the maxillary teeth land nicely on that wet, dry border of the lower lip. Sibilant sounds, 66. Zoolander, I don't know, I can't think of a cool Z word, but when you try to say that S or Z sound, the tip of the tongue goes up a bit toward the palate. 66, so it barely kind of touches the palate. How does that change with our prosthesis? Well, if it's too thick on the palate or the teeth are positioned off, obviously that can be affected. Bilabial sounds is, just like how the word indicates that we have to use both upper and lower lip. So I think there was like a little clip online I saw the other day. I forget the word, but this guy was trying to say this word that requires us to say, use both lips, and he tried to say it with his mouth open, and it just doesn't work. So if you try to say Bobby without lips, with your mouth open, it sounds like it just doesn't work, right? So that's why it's called bilabial sounds, B sounds, P sounds, M sounds, W sounds, all of those. And what happens if teeth are positioned improperly? What happens to those sounds? You should know that. If the teeth are too long, then the F sounds will sound like a V sound, because it's just literally digging into your lower lip. Simply, sometimes you just try it yourself, because most of us can reproduce these sounds properly, if not all of us. So again, more sounds. You might want to think about why sometimes denture patients produce kind of a whistling noise. They'll actually tell you after dentures are delivered, not before too long, as they start to function, including talking, if they don't notice it, their loved ones will say, "Dad, you sound like you're whistling every time you say certain words." And these words are listed here, these sounds. Or sometimes they'll say, why do you have a lisp when you wear the dentures, and you don't when you don't wear dentures? So you got to think about something that happened. And obviously it has to do a lot with the teeth positioning, but sometimes also the thickness of the denture base, especially in the palate. So you want to know that. Consonants also, not a sound that we I at least test very much. Speaking space, definitely something that I test often. And it can be both in anterior and posterior. Now, when you say 66, the teeth don't really come together, both anterior and posterior. And you'll see that little bit more space in the anterior than posterior. It's just a way, because of our anatomy. As you go posteriorly, we have less space, but the teeth still separate somewhat when you say S sounds. So you'll see a little bit of spacing on the right picture when the patient is trying to say 66. Posterior, as I said, you see a little bit more space. I'm not going to test you on these classes, but you should at least know that there's speaking space in the posterior as well. So again, say 66, even your posterior teeth, really, they might touch lightly, but they don't come together. Because if you try to say 66 with the teeth closed, you sound like this. Anyways, more speech stuff. Obturator is something that helps with, I mentioned that if patient has some sort of surgery on the maxilla, we need a prosthesis to replace all of that anatomy. But it also restores function because this patient is going to have some issues. Well, which part of the speech? Obviously it's not audition, it's not neural integration, it's not respiration, maybe a few others that you should know of. So that's what the obturator looks like. It really goes in to close all that space so nothing is communicating. What happens when there is extensive procedure done in the mandibular arch? That can affect speech too. So you should know that as well. Only 2 questions on digital technology, and these are very, to me, kind of a common sense thing. If you by now you've seen at least a couple presentations on digital technology, but my questions on this topic was very straightforward, and only 2. Single maxillary denture, again, my favorite topic. I tried to transcribe what Dr. Driscoll said, something that you should all know. If you forgot everything from this episode, the keyword is stability. Retention and support are important for ensuring success of a denture, especially a single maxillary denture. But without stability, really, retention and support just can't ensure success. So that's what I learned from this topic, but thanks to Dr. Driscoll, and as a resident, this idea just got deeply embedded in my mind that I really don't forget how important the balance of the denture is, because if the balance isn't there in the denture, opposing natural teeth, and we're not going to have stability. Once stability is out the window, everything goes out. Retention support doesn't matter how retentive it is, doesn't matter how much ridge and broad keratinized tissue the patient has. Without stability, to me, just like Dr. Driscoll said in this episode, those 2 things don't really matter, and there's no success as a result. He mentions what we sometimes call roller coaster occlusion, because it really looks like roller coaster going up and down or down and up. And that's because the occlusal plane has so much discrepancy anterior posteriorly, maybe left and right. We just can't balance dentures very well with this type of occlusion. So we have to change that. And that's what his article is about. That's what this whole topic of single maxillary denture is about. Sometimes we simply take the teeth down a bit. So it's a subtractive method. Sometimes we build the teeth. That's additive method. Sometimes it's little, sometimes it's extensive. And that's what determined his classifications too, which I would say you don't need to know. A lot of classifications that I'll tell you need to know are just kind of applying to your routine patients, because even this type of patient you won't see. They end up going to postgrad usually, if they can afford it especially. He mentioned combination syndrome by Kelly. Ellsworth Kelly. And then there's another name after that, Saunders. Adding a few more to these five. What is it, 4? 5, yeah. So you should know these 5 factors of syndrome, even though he says because it only involves the mouth as a single organ, it's not really technically syndrome, because syndrome, by his definition and anyone else's, it involves multiple organs. But that's just a side note. And again, I try to transcribe here what was important in this on this slide. When we are designing a surgical guide, because we have to reduce tuberosity that has downward growth, well, how do we do this? Do we just send the patient to oral surgeon, cross our fingers, and hope that they'll reduce just the right amount? Or do we actually work backwards from teeth arrangement that is idealized in the maxilla? And based on that, we figure out how much tuberosity should be adjusted. Obviously, it's the latter, right? Okay, this is a part that I remembered that was not covered in the second or first lecture because we didn't have enough time. So I'm hoping everyone looks at, I'm sure you will, because I'll mention it in this review. It's basically the electronic patient record form for any patient going through removable pros treatment in the clinic. So in the Axiom, you actually see this. And as Dr. Rivera constantly reminds you, you need to fill this out. And so far, I've seen, good ones, but also have seen some inaccurate ones. So I wanted to really go over this, especially some of these classifications. Once we go through it, it's hard to forget. So let's start with the first one, tongue position. And some of these classifications you can try to evaluate in your own mouth as well. If you just try to relax and see where the tip of your tongue goes, mine goes to the lingual side of my mandibular anterior teeth. And that's usual, but also most favorable for a denture patient, because what happens without teeth over time, tongue position and the contour of the tongue can change for worse. So denture treatment outcome becomes less favorable. Class 3 is the worst one, where the tongue really retrudes. Sometimes it even goes up. When that happens, you'll find the patient complaining a lot that the lower denture just won't stay put. When we talk about the depth of the floor of the mouth, especially in the posterior region, where the retromylohyoid space is, we mentioned this classification by Neal. And we mentioned this area, we want to look at this area because if we have an undercut in the retromylohyoid space or area, we can use that to enhance retention of the mandibular complete denture. Well, how do we assess this area accurately? Well, it's not very scientific, but you simply place this mouth mirror right in here, where there's a little shadow cast in this area. You place it as deep down as possible without hurting the patient, and you ask the patient to move the tongue, and it's usually moving the tongue forward. When you see the mirror popping up abruptly, entirely, then it's telling us that there's not much depth going on here. And that's class 3, and it's the worst prognosis in terms of retention of the mandibular denture. So hopefully we have stability from the balance of the teeth, but if you have this mouth mirror staying entirely in this region, even when the patient's tongue is moving, that's class 1, and we should definitely engage this area with the denture, or at least try to, and give the patient as much retention as possible on this denture. There is also classification of the soft palate. Few of you who have worked on denture patient, when I was covering clinic, I might have done this with you. I would ask you to get a Thompson stick or indelible marker, and I draw basically an arbitrary line connecting 2 hemular notches. And I would say, and then I would palpate the areas anterior and posterior to it. I will also ask the patient to say, and I say where the vibrating line is, and I tell you, or I walk through with you how much soft tissue we have for the posterior palatal seal. And it's that displaceable tissue that I can palpate ever so slightly with a T-ball burnisher, not the movable tissue of the soft palate that moves when the patient says, ah. So ideal situation that we have a lot of this displaceable soft tissue, especially distal to hemular notch. Now, you have to look at it also from different angle too. So if the posterior aspect here is drooping down very abruptly, as opposed to being relatively flat for a while, for some distance, those also can play a role in the retention and success of the maxillary denture. So class 1, in terms of looking at that angulation, is relatively flat. I don't know who came up with this 10 degree. I don't measure, but if you wanted to have some number, maybe it's 10 degrees. Class 3, on the other hand, is very abrupt, very steep curve downward. So again, someone came up with this number, 70. Somewhere in between is 45. So angulation can have something to do with whether the treatment outcome will be favored or not. But along with that is this distance that I just mentioned. And this is just as important, maybe more, that we actually have a lot of real estate in the soft tissue area that's not moving. It's displaceable, but it doesn't move. So class 1 is when we have just miles of soft tissue. Well, miles is a little bit exaggerated, but we have 5 to 12 millimeters of this displaceable tissue distal to that line connecting hemular notches. Okay, so not only it's flat, but we have quite a significant area that we can have the denture to sit. Going the other way around, it's actually nothing behind the line connecting hemular notches. It's only anterior, about 3 to 5 millimeters. And on top of that, and it's because the soft palate is dropping down quite steeply. So that gives us least chance of getting good retention. And somewhere in the middle, we have class 2. So this is one of the first things I will look at with any edentulous patient, especially with maxillary edentulous area. And then after doing that, we've kind of figured out, okay, how much retention can we get from both arches, mandibular and maxillary? Now we look at the arch form or the ridge form. The ridge form comes in two. So when you cut the ridge in cross section, you get some sort of shape. Now you can't really do this without a CT scan, or unless you do surgical exploration. You reflect the soft tissue and try to look at the bone. You can also guesstimate from just appearance of the patient's edentulous anatomy or looking at the cast. It's not always accurate though, because soft tissue can be kind of misleading, especially if it's really keratinized and thick. But we can describe the ridge form into 4. I mean, I think there may be more, but I just looked at 4 common ones. And here's one that's kind of broad, tall, and U-shaped. And here's another one that's a little bit less broad. Now here's one that's really thin, and it's even resorbed. And then here's one that's very resorbed, completely resorbed, if unfortunately, and it's becoming just flat. So there's not much grabbing the denture, if you will. And obviously, knife edge and the really resorbed flat ridge show the least promise for successful treatment outcome. And then we look at the overall arch form. And you can simply look at it from the occlusal view and try to figure out the shape of the arch. I don't really see this having too much effect on the treatment outcome, especially in a negative way. But sometimes it does play a role in terms of what kind of teeth we pick. Square arches tend to have square shaped teeth. Triangular arches tend to have triangular teeth. It's not always the case, but I do see that from time to time. And I think this is the last aspect is when the patient has a really high palate, and we call it high palatal vault, we often see that it's very difficult to have denture base adapt nicely to this high ceiling. As a result, what happens is if we do this, especially conventionally processed dentures, we find this area becoming a stress point or stress area. It tends to be a common site for fracture of the denture because it's just not well adapted. It comes out relatively thin. But if we do it digitally, perhaps the denture material is stronger and adapts better. So, high palatal vault really no longer becomes an issue. Most of us will see in the clinic kind of an average size of the height of the palate, which tends to be favorable for both retention and the strength of the denture. Anything very flat and low palate, that also tells us the ridge height is not very good. So there's not much of stability because it doesn't resist any lateral forces. This patient, I'm starting to see some in your clinic. So this becomes perhaps sometimes significant. Okay, just before 10, I hope that would be helpful for you. I try to do again, just include the topics that will be on the exam. Between now and Tuesday morning, any questions you have, please email me. Otherwise, those of you who are in the audience on a short notice, thank you. Okay, I have to go for now. If you have questions, let me know. All right, thanks everyone.